Alrighty, so we should get going. It is just after 11 o'clock. So we'll introduce ourselves first. So I will introduce myself and then I'll throw it over to you, Ben, and then to you, Aira. So just a really quick introduction. I'm Dr. Nerida Richards, one of the original founders of FeedXL. If you don't know FeedXL, it is a nutrition calculator for horses. So it allows you to really quickly and easily figure out if what you are feeding your horse is actually meeting your horse's nutrient requirements. A big part of what we do at FeedXL is education, which is why we run these masterclasses. And we're very fortunate this time to have Associate Professor Ben Sykes joining us, who for me is just the world's guru on gastric ulceration. We learnt a bunch from him last night. I'm sure we're going to learn a bunch from him again today. So I'll leave that there for me. So my background is nutrition. My PhD is in grain feeding in performance horses. And I've been working as a consulting nutritionist and also as the FeedXL lead nutritionist. I think I started my PhD in 2000. I've been working on horse nutrition ever since. So I'll hand over to you, Ben.
Yeah, so Ben Sykes, I'm an associate professor in equine internal medicine, actually at Massey University in New Zealand, although I'm currently stranded on the east coast of Australia, courtesy of COVID, but working remotely. My background is I trump Nerida by 10 years. I graduated in 97 from Murdoch in Australia, and then did some time in racetrack practice in Australia, and then time in the States, just outside of Washington, D.C. in Northern Virginia, and then did a stint in Finland for 7 years and back to Australia approximately 11 years ago. So I've worked with sort of a range of horses, really initially focused on the high performance end of things, but certainly particularly the European experience was very much the riding horse experience, or the what I call the sports horse experience. The warm blood population is used for a range of different things. Back in Australia, I play polocrosse and have a lot to do with that sort of part of the world. My particular research interest for probably the last 15 years has been gastric ulcers, or my clinical interest has been gastric ulcers, and it's been the focus of my research over the last 10 years. I did my PhD in sort of around about 2016, and that was looking at omeprazole and factors that influence omeprazole efficacy in the horse. And around the same time, I was also the lead author on the European consensus statement on gastric ulcers in adult horses, and that's a document that's sort of used around the world as a benchmark veterinary document for diagnosis, management, and treatment of gastric ulcers. So really happy to be here and looking forward to another active discussion.
Thanks, Ben. And Aira, so good to have you, Aira.
Hello, everyone. I'm Aira. I'm part of the support team here at FeedXL. I bet you've met me via email or seen me on the Facebook forum. I'm originally from Finland, and I have a master's degree in animal nutrition. And then I've just kind of went from ruminants and studying calves to actually studying equines, and I'm still on the same path. At the moment, I live in California, close to Sacramento, and I work here as a private nutritionist. But also, I'm every day involved with FeedXL, which is awesome. And today, I get to be a part of this masterclass. Yay!
I love your energy, Aira, and we truly love having you at FeedXL. You do such a great job of what you do. So if anyone does reach out to support at FeedXL, most likely you'll come across Aira, and it will always be a really lovely experience. So Ben, we started last night. So we did this session last night, and we'll probably refer back to last night a little bit, just because we got some stuff sorted out last night, and there were some things that we talked about that I want to make sure that we cover again today. But where we started last night, Ben, was just getting you to actually define what is a gastric ulcer and talking us through the terminology, which I think becomes very important as we continue to the discussion. So if you could start there again, that would be great.
Yeah, absolutely. So when we start talking about gastric ulcers, the really important thing to do is to recognize the terminology that we're using and exactly what we're talking about. So because it frames the whole conversation, and throughout this conversation, we're going to move between terminology, and we're going to move between the terminology of squamous disease and glandular disease. And it's absolutely critical that we identify the difference. It's actually got to the point where it's really outdated to actually say my horse, if we talk about from a veterinary perspective, the horse has ulcers. It's not specific enough. It's not accurate enough. And so what we're talking about is, if we look at the slides here, if we look on the left, sorry, up the top right-hand corner here, the horse's stomach's this big chamber. It's sort of 12, 15 litres, depending on the size of the horse. And we have two regions to the stomach. The sort of the top third to half of the stomach is lined by a mucosa called the squamous mucosa. And that mucosa is the same, that lining is the same as our esophagus and the same as our skin. When we get into the bottom half of the stomach, which is this area around here, we have the glandular mucosa, and I'll show you some pictures of that in a second. Now, importantly, they're two very different tissues, and effectively the glandular mucosa is like our stomach, it makes acid. And they're two very different tissues, and what's relevant about that is I sort of consider them the odd couple. They happen to share the same accommodation, but they have nothing in common in so many ways. And what's critical about that is what we know about squamous disease, we cannot directly extrapolate across and apply to glandular disease. And so when we're talking, as we talk through today, and we're talking about the risk factors for disease, the treatment for disease, and prevention for disease, we have to be very specific as to whether we're talking about squamous or glandular disease, because there's actually very little crossover. When we look at the squamous mucosa, what we have here on the bottom left is a nice, healthy, whitish, yellowish, slightly yellowish, beige colored, that's the squamous mucosa. And as I said, that's sort of like our skin. And this area here is the start of the glandular mucosa, and the glandular mucosa extends all the way down into the pylorus, which is the emptying into the small intestine. And we call this line between them this sort of imaginary line. It's a little bit like the equator. It's there, but not really there. The margo picatus, it's just a distinguishing point. And as we move across here, what we can see is if we expose the fundamental problem the squamous mucosa has, is that it doesn't like acid, and it lives next to an area that makes acid. And so all of our disease in the squamous mucosa is primarily caused by acid exposure, and a variety of factors impact upon that. And so what we see when we get acid exposure, we start to see thickening, which is this sort of first stage, what we call grade 1 lesions. And that's the same as if we walk around in bare feet, the heels of our feet will start to thicken, and that's the stomach just having exactly the same response. If we continue to insult, or we exaggerate the insult, then we start to get specific lesions, and as we come across to the right-hand side, we get very severe lesions. If we go to Google and we Google gastric ulcers in horses, virtually everything that comes up is about squamous disease. And we know a lot about squamous disease, and we're going to spend, a lot of time talking about that today. But as I said, we have to recognize that that's different from glandular disease, and we cannot apply one to the other. So when we talk about glandular disease, we're in the bottom half of the stomach here. We're emptying into the small intestine. This is an area that normally lives bathed in very concentrated acid, a pH of 1 or 2, so extremely acidic environment. But it's got a strong protective mechanism. If you sort of have a look at this shiny appearance to it, there's like a little mucoid slime that protects the glandular mucosa. And so this on the left here is a nice, healthy stomach, and then we come across to one that's got a little bit of inflammation, and then we start seeing small focal lesions, and we start seeing these bigger lesions over on the right. And this one here that we see second from the right, that'd be a very typical warm blood lesion that we see in our sports horse population, and it'll be about the size of my finger. So it's, it's a significant size, and it's got a bigger ulcerated or erosive surface on top of it. That sort of alludes to one of the really key distinctions between them is the populations that we see them in. So we'll talk about this more, but the squamous disease is associated with some primary dietary and exercise factors, and we see that in horses that do that. A really important early message and take-home message is we see glandular disease in a whole different population. We can see it in that population, but we see glandular disease in a population of horses that we would traditionally say are at low risk of ulcers. And they may well be at low risk of squamous ulcers because they don't have those risk factors, but they can still get glandular ulcers. And so it's really broadened our scope when we talk about ulcers. It's broadened the populations that we talk about, and it's really come back to having to say that we're talking about squamous disease or glandular disease rather than this generic term of ulcers per se.
Yeah, essentially it's two different disease conditions.
Yeah, they just happen to live next to each other. And we need to really think about them as two different disease conditions, because if we want to reduce the risk of ulcers in our horse, we have to reduce the risk of two diseases, not one.
Yes.
Yeah, and that to me is possibly the most important take home of our current messaging of when we talk about ulcers.
Yeah, I mean, just the last few conversations I've had with you, Ben, it's really shifted my thinking around this. Like I'm very guilty of talking about ulcers as ulcers. And I guess, until a couple of years ago, the glandular ulcers wasn't really, we didn't hear about them much. We didn't see them much. But you were saying last night, the scopes weren't long enough to get down and really have a good look at them. So they probably have always been there. We just didn't realise they were always there. But it's so obvious to me now that they're two different conditions, and what we do to treat them and also to prevent them is a two different things. Well, they're multiple things, but they're in treating and preventing one and not necessarily going to treat or prevent the other.
Yeah, absolutely. Yeah, there's a great question there, which I think follows on logically from Michaela, and sorry, they're just bouncing, and Linda as well. So Linda, is there a relationship between squamous and glandular ulcers? And the answer is no. If you've got one, you're no more likely to have the other, but you can have both. So if you've got risk factors for both, you can have both. If you've got, for example, exceptional nutritional and exercise management, you're probably unlikely to have squamous, but you can definitely still have glandular. So they can occur independently, or they can occur concurrently, but not necessarily dependently. And then the other question was, do we see differences in the symptoms or clinical signs? And we don't have a great grasp on glandular overall. So a lot of it's sort of opinion rather than fact. But for me, I think there is a difference. I think for squamous, the dominant thing that we see is poor body condition, unexplained weight loss, and changes in eating behavior. And really, in many ways, it's like heartburn in people, and it's the same disease process as heartburn in people. And I think that the signs that we see reflects that. For glandular disease, I think we see much more overt behavioral signs associated with true pain. And I guess you could argue the difference between discomfort and pain, but I think we're actually talking about true pain. And so we see manifestations of true pain, which are irritability, reluctance to work, changes in personality. Anyone who suffers chronic pain will tell you personality is a big thing that suffers very early on, these sorts of things. And they're the sorts of things we see. I think we also see a stronger link between glandular disease and colic. That if I see a horse that has multiple episodes of colic, one of the first things I'm going to do is go looking at the stomach, and I'm primarily looking for glandular disease, although obviously I wouldn't ignore squamous disease. And then just to clarify for Genevieve there, no, glandular is not the hindgut. So we're still talking about the stomach right up the front, and then we've got 22 yards of small intestine, and then we get to the hindgut. And the hindgut's a great conversation for another day, but we're very much still focused in that chamber of the stomach.
Yeah. Ben, something you mentioned last night too when we were talking about symptoms was you said with the squamous disease, the reduced feed intake, you did say, they probably will not eat so much of their grain, hard feed, concentrate, just depends where you are in the world as to what you would call it. But something that sort of stuck out to me as being really interesting was that you noticed they also decreased their roughage intake. So their appetite.
So I think when we think about prevention, one of the greatest fallacies that we've perpetuated on the world is the idea that ad libitum, or unrestricted roughage is protective against squamous disease. The problem is they have to eat it. It's not the access that's the important bit. They have to consume it. And these things seem so obvious when you think about them, but I was down doing a study at the racetrack not that many years ago, 5-7 years ago. I was well into my gastric ulcer career, and this had never crossed my mind. And I went down to scope some horses. It was a follow-up scope. It's really hard keeping horses in the study. I'd kept them all but these last 5 in through. And I went to scope them, and the trainer had hay nets in every single stable. Beautiful, lush, lucerne alfalfa hay. And I was like, bugger, I've just lost 10% of my population. I thought, you know what? I'm going to scope them anyway, because I might get away with seeing the squamous even if I can't see the glandular. Scope the first horse. The stomach was pristine, empty. Scoped the second horse. It was empty. And I said to the trainer, I said, how often do you replace those hay nets? He said, about once a week. So these horses had unlimited access to hay, but they were only consuming 1 kilo a day. And that's nowhere near enough to have a protective effect. So what I think we're dramatically underestimating these horses with squamous disease that are on unrestricted hay is that they just reduce their voluntary intake. And that's why they have unexplained weight loss. They may or may not eat their hard feed, but they you know, it's much easier to eat ice cream than it is to eat your vegetables, right? So
Yeah.
if it was me, I'd eat the hard feed and leave the hay, and I think many horses do that as well.
You came across this yesterday, Sam, or the day before, talking to a vet who was dealing with a racehorse, and the racehorse had ad lib access to lucerne hay, or the trainer said, oh, he's got as much lucerne or alfalfa, it's the same hay, we can call them different things in different parts of the world, as he wants to eat. And Sam said, well, how much is that? And what did he say, Sam? Half a biscuit a day?
Yeah, so I said, oh, how much does the horse eat? Is that like a biscuit morning and night? He's like, oh no, a biscuit, so half a biscuit in the morning and half a biscuit at night, which should probably be about 1.5 kilos per day, of lucerne or alfalfa. And that was all the hay the horses were getting, and hard feed on top of that.
And that's a flake for those playing along in the Northern Hemisphere.
Less than 4 pounds for anyone who speaks in pounds, but it's not very much hay in a day, and yet the trainer was of the belief that horse had as much hay as he could eat. But exactly what you're saying, Ben, is not eating very much of it, so it's not going to be protective.
So when we start pinning down on individual horses and worrying about that, one of the things that we need to do is actually measure their roughage intake and say, are they consuming an adequate roughage that we would expect to be protective? And volume of roughage, we can talk about quality later, but we're just talking volume here.
Yeah. Is there anything you wanted to add to the symptoms discussion, either for squamous or glandular ulcers?
I think we'll come back to it. I mean, I think the overarching thing for me is that when we think about so for the chat there, a biscuit is a flake. It's an Australian, North American terminology. We have stalls, boxes, all sorts of things that go horribly wrong when you change countries and terminology. I think the overarching thing for me is that the glandular disease we see in a much broader range of horses, and we see in horses that traditionally 5 years ago we would have said this horse has got some problems, but I don't think it's ulcers because it's so well managed. It couldn't have ulcers because it's so well managed. Yep. And so we see, because of the risk factors, we see it in a totally different population or in a much broader population. And we also see it in horses. We'll talk about risk factors today, but it's important to put up there right from the get-go. We also see it in horses with zero risk factors. And that's probably because we haven't identified all the risk factors yet. So there are horses with absolutely spotless management that still get, some of them still get squamous, although that's far less common. But they'll have horses with spotless management that still get glandular disease, and that's an individual horse susceptibility thing. That's not necessarily an environment-related thing, because glandular disease is not all about environment, whereas squamous is.
Yeah. Yeah. So you're saying that the horses can have pristine management and yet still have glandular disease more so than squamous. Their management is pristine. It's unlikely that you're going to get squamous disease, but it's possible to have glandular. How much of a role does what we do with our horses? I mean, you look at a horse as a wild animal, and they don't hop on trucks or trailers and go to competitions and stay on the road for days, weeks, or months at a time. How much of a role does that have in the glandular disease that you see in horses that are otherwise really well managed? So
we know that. So I'm just trying to find a slide here for you. We know that squamous disease, for me, it's about the big three. So when we talk about squamous disease, I'm talking to myself because I'm pressing buttons here in the background. When we talk about squamous disease, we're talking about the amount of carbohydrate in their diet, the amount of roughage that they consume, and the amount of exercise they do. And so they need low carbohydrate, high roughage, and we try to regulate their exercise. And so for me, when we put that together for squamous disease, what we're looking at is something that looks a little bit like this. And so for me, it's the three factor effect, right? It's the dominant three factors. And so it's increased carbohydrate, and we can talk about that separately. Inadequate roughage. What's adequate roughage? At least 1.5 to 2% of their body weight, but we'll talk about that some more as well. It's not just the amount they consume, it's when they consume. And it's the amount of exercise they do in any given period. So if we take a week, it's the amount of time they spend exercising at a trot or above. And so, long warm-ups and long cool-down periods for horses are, deleterious to the stomach, at least the squamous mucosa. When we talk more directly about your question there, sorry, I'll just pull up another paper here. When we talk more directly about your question here, it relates to, we did a study looking at feral horses in the UK versus, this is going through an abattoir, and these were feral horses versus domesticated horses. And what we saw is that on the left-hand side here is squamous disease. And so this is no lesion, this is more lesion. We saw that, not surprisingly, the domesticated horses had a moderate amount of squamous disease. And we saw some squamous disease in the feral horses, but not a lot. We saw a similar pattern in the glandular, that again, the domesticated horses had more. And we saw a few there, but it was only a couple of horses. It was only a handful of horses that had glandular lesions in the feral horse population. And so I think the take home from that is they're both diseases that we induce with management and domestication, but we induce them differently. We induce squamous disease through the big three, and then there's a whole bunch of other things that potentially contribute, but they're the dominant factors. The things that induce glandular disease are different, and we're only just starting to get a grasp on what that might mean, but that's sort of, that's where we are at the moment. But it's not the same as the big three for squamous. That we know for sure.
Yeah. Can I just get you, Ben, to put up that your big three image again? Because last night you had them with those three sort of stacked on one another, and I think that was an important distinction to make, that the increased carbohydrate, so increased amounts of starches or fermentable carbohydrate from things like grains, reduced roughage, and then the amount of work, that the three big risk factors for the squamous disease, and then Ben will show you, they kind of cumulative. So the more of those risk factors you've got, the higher the disease risk. Yeah, I think it's a good one. So if you manage one, so say for example you manage the amount of exercise. I have to say I manage the amount of exercise my horses get very well. They definitely aren't at risk from squamous disease from too much exercise, unfortunately. But if I was managing that really well, but was still feeding them, say, a really high grain, low roughage diet, they're still going to be at risk because I've only knocked that top block off the risk profile there.
Yeah, and it's the same for grain, right? So when we talk about squamous disease, or traditionally when we talk about ulcers, but now we're going to switch to that and say when we talk about squamous disease. So just to answer the question there, Michaela, we're talking about more exercise leads to increased risk. And that's because as you exercise, the horse's stomach, they squeeze their abdominal muscles, and it's like an hourglass effect, and it pushes the acid up physically onto the squamous mucosa. And that's anything from a trot or above that the horse is doing that. And the longer you hold that, the longer that squamous mucosa is going to be getting exposed to acid, the greater your risk of squamous disease. So it's about duration of exercise, not intensity. And we'll come back to that when we talk about glandular disease. So the other really important thing here is that, when we get into these conversations about ulcers, one of the things that sort of reflex happens is that we demonize grain, and we demonize concentrate feeds. And what this tells us, what this sort of is trying to tell us is that that's only part of the story. And if we only take that out, we're not addressing the thing. But the other thing is that the analogy that I use for many things, apparently, based on last night's discussion, is it's like red wine, right? The carbohydrates are like red wine. The concentrate feeds are like, processed feeds. There's a lot of really good things about them. And if we enjoy them in moderation, they're actually good for us, right? We know that 1 glass of red wine a day for the adult male and half a glass for female is good for you, right? There are health benefits towards that because of a range of factors. If we drink 2 or 3 bottles a day, not so good, right? It's not going to play in our favor. And so when we think about carbohydrate, it's about moderation and application, not necessarily about yes or no. And people like absolutes, but the world of things are grey. And what we're trying to do here is basically take this risk as we go across on the right for squamous disease. the more grain we feed them, the less roughage we feed them, and the harder we work them, the higher the risk. And what we're actually trying to do, if we only remove one factor, which is grain, we only come back this far. Oops. But if we can address all three, we're going to push further back onto that as well. So it's about trying to reduce all three, not just, you know, focusing on one, which frankly is often done for commercial purposes, not for actual, you know, legitimate purposes, if that legitimate medical purposes.
Yeah. I mean, it's good news for people like me who, even when I am in full riding mode, I only manage to get out about 3 times a week. So it makes me feel better about only riding that often, because I know that the risk of ulcers is going to be lower. But getting the diet right, and that, you know, being FeedXL, we're all about getting the diet right, but, you know, minimizing. Well, probably coming at it from a different angle is doing as much as you possibly can in a horse's diet with forage. So if you can feed your horse on a forage only diet that's balanced, so forages are not going to provide enough vitamins and minerals for 98% of horses 98% of the time, so you do have to have them balanced up. But if your horse can exist on a forage only diet, then that's the best possible thing you can do for your horse. Don't feel like you need to add any sort of hard feed, grain-based feed into the diet. If your horse is working harder than what your forage that you have available can support them, so, you know, if they can't maintain their weight and their energy level just on forage, then yes, you're going to have to add a higher energy feed stuff in, but only add enough in to meet energy requirement. I think it's often overestimated how much grain a horse actually needs. Racing industry is a classic example of this. They've gotten caught up in thinking that, you know, grain is what provides the glycogen for the muscles, and that's what's going to, you know, give their horses the energy to sprint. But they've taken it too far and causing a whole bunch of other issues. But one of the things they do is put those horses at increased risk of squamous disease with so much grain. And when we get a racing horse's diet right, we can bring the grain amount right down. I mean, Sam and I have standardbreds racing on 2 to 4 kilos of grain a day, and can manage to do the same thing sometimes in racehorses as well. So, you know, don't think that horses in hard work need a lot of grain. They don't, if you get the forage part of their diet and their gut healthy and functioning the way that it should function.
And we'll get to this, but when we do that, we dramatically reduce our dependency on medication to manage disease. And that's you know, that's something that I think we should be doing. And I put my hand up for conflicts of interest. I work for drug companies. I work for an omeprazole company. I work for a supplement company. As I said yesterday, if you work for enough people, you run out of conflicts of interest because you have a finger in every pie. But I think, you know, our responsible use of medications is an important thing. And there are, omeprazole is not a universally safe drug. It's a drug with a very high safety threshold. It's a drug that's been a great introduction, a great addition to our toolbox for managing disease in the horse, but it's not universally safe. There are still some downsides to long-term omeprazole, and so I cannot overstate the role of that nutrition as the foundation for which we're going to manage disease across the board. And it's not just that nutrition is good for the stomach; it's also good for the hindgut. It's also good for vast majority of muscle diseases. There's a lot of reasons why we should be feeding horses the way that we recommend for their general health, not just being focused solely on the stomach.
Yeah. So I think something really important too is that to realise that every horse is at high risk of gastric ulceration, be it squamous or glandular. I mean, seeing it in wild populations shows us just how prone they are to it. And so, you know, don't wait until your horse has an issue before you change his diet to reduce the risk. I mean, these changes that we're talking about in diet are going to, exactly what Ben said then, are going to benefit every other part of the horse's gut, as well as its overall health. So the sooner you can start feeding and managing a horse like it's at high risk of gastric ulcers, the better, because the reality is your horses are at high risk of gastric ulcers just because of the, I might say, stupid way that their stomach's been set up. It's something that I'd really like to redesign.
Yeah, and you know, I have no skin in the game for nutrition personally. For all my conflicts of interest, I have no skin in the game for nutrition. I have skin in the game for horses with healthy stomachs, and that is the way that we go about that, or healthy gastrointestinal tracts in general. And low carbohydrate, high fat feeds and these sorts of things, they're all part of our strategies to we don't have to eliminate carbohydrate. We just have to minimize carbohydrate or keep it at a certain level, and then get our energy sources from elsewhere and our nutrient sources from elsewhere.
Yeah. Just having a quick look. So Ben, if you've got a horse that is diagnosed with ulcers, be it via gastroscopy or diagnosed by some other means, what do we do then? What are some of the treatment options that are available for both squamous and glandular individually?
Yeah, so I think the first thing is to look at the process of diagnosis and know exactly what you're dealing with. So there are differences to how we manage squamous disease to how we manage glandular disease, and then there's going to be differences to how we put long-term interventions in to stop reoccurrence. And every time we put an intervention in, most of those have a cost. It might not be a financial cost, it might be a management cost. It might, so we want to know that we're getting them where they need to be, and we're spending our resources, whether it be money, time, effort, whatever, in the right place. If we have unlimited resources, awesome, we can always do it. But realistically, when we've got lives, that we always have to find a balance somewhere. And so knowing exactly what you're dealing with, making sure that you look at gastroscopy is going to remain the cornerstone. It's going to tell you whether you've got squamous disease. It's going to tell you whether you've got glandular disease. It's going to give you a baseline for rechecking that horse, particularly for glandular disease. I think it's really important to get follow-up gastroscopy. Even if you get improvement of clinical signs, you want to make sure that you've got resolution before you stop, because if you stop too soon, they're just going to slide back to where they were in the first place. If you can get them resolved, then you can try and hold them there, but you don't want to get them halfway and stop the treatment because they just bounce straight back. And gastroscopy is really the only way to do that. The fecal blood test is popular because it's easy. But there are a lot of things in life that are easy, like eating junk food, that aren't necessarily good. And I probably put it in that category. That test is not reliable enough to give accurate information at an individual horse level. There's been 3 independent researchers try to validate it, and no one's really been comfortable to validate it adequately. I looked at it in a racehorse population, and it simply was not accurate. It simply could not give us a reliable answer. So there is a cost attached to gastroscopy. There is an inconvenience attached to gastroscopy. But given where you're about to go and perhaps what you're about to spend, not just in the short term on omeprazole, which in Australia is relatively cheap, but in the rest of the world is still quite expensive. But in the long term, in terms of management, in the long terms, in terms of supplement, in the long terms of how you look after your horse, knowing where you are and what you're dealing with is really important. Because we have other diseases like sand that completely mirror gastric ulcers. Sand in the horse's abdomen looks exactly the same as gastric ulcers in many cases. So we need to know what we're dealing with.
Yeah. The other thing too with the fecal blood, and I think it's been really highlighted today, is that it's not going to tell you where the gastric ulcers are. So even if it was accurate in diagnosing ulceration, it's not going to tell you which disease you're actually dealing with, and therefore what treatment protocol is actually going to work for that horse.
Yeah, and so then when we get to treatment, we manage them differently or we treat them differently. And then we get to prevention and we do it differently as well. So for treatment, for squamous disease, the equation's pretty simple. Squamous mucosa, acid, squamous mucosa doesn't like acid, so you get lesion. If you remove this acid, the squamous mucosa is going to heal. And it has an enormous proliferative capacity and enormous capacity to heal. And so if we can get effective acid suppression, we'll get healing within 14 to 21 days. And so the label course for omeprazole in most places around the world is 28 days, but the current consensus recommendations back at 21 days based on the evidence that's available, that if you're going to get healing, you're going to have it by that 21-day phase. It's important to recognize that when we talk about omeprazole and squamous disease, it's not a universally effective drug. We have about 25% of horses, depending on the conditions and the population, we have about 25% of horses that only partially or don't respond at all. So again, we can't just put the horse on and assume that the problem's solved. We need to really consider that follow-up gastroscopy. We need to, recognize that there are subsets of populations that do not respond to the drug. And that's simply because they don't absorb the drug very well. There's approximately a quarter of horses don't absorb the drug very well.
So that's really.
Sorry, go ahead.
Sorry. That's a really important point for horses that are not scoped, diagnosed based on symptoms, but then when put on omeprazole don't respond. And I think probably the common thing is, well, it didn't respond to omeprazole and therefore it can't be ulcers, it must be something else. But what you're saying is that it could be ulcers, it's just that horse could be in that subset of horses that does not respond to that drug.
Yeah, it can be a non-responder, or we have this idea of threshold for clinical signs. So generally for squamous, if we get good acid suppression, we get quite immediate relief of clinical signs. They change fairly quickly. For glandular, that's not necessarily the case. For glandular, it seems that some horses, we need to bring their lesion all the way back down to here before they'll have a change in clinical signs. And we don't have this data published yet, but we did some stuff. A colleague that I work with did some stuff, and they were looking at, resolution of signs. And it really wasn't until the horses were back to grade 0 that we saw consistent resolution of signs. And so we might see change, but we don't necessarily see resolution. And one of the things that factors into that also is we have to think about what signs the horse is showing and when it's showing them. Because if we give omeprazole in the morning and we ride 3 hours later, it's probably going to help the horse during that period, but it's not necessarily going to be helping it 12 hours later or something like that. So that comes back to the importance of rescoping, because it's the duration of acid suppression that's going to dictate healing. It's the timing of acid suppression that may dictate response in terms of clinical signs.
Mm-hmm. Mm-hmm.
If we talk about glandular, and then we talk about glandular treatment, then we've got a couple of options. And it's a personal preference, and there's a geographical variance in this. I still personally primarily use omeprazole, but I always use it in conjunction with sucralfate as a coating agent. So omeprazole's there to acid suppress, and sucralfate is there as a sort of a band-aid, for want of a better term, to coat the lesion and to provide some growth factors and stuff like that. When we're treating glandular lesions, we need more potent acid suppression than when we're treating squamous lesions. And so we need to really focus, in general, we need to focus on our drug absorption and activation, but it's particularly important for glandular lesions. Mm-hmm. What that means is that we know that when we fast horses and we give the drug on an empty stomach, we get 2 to 3 times as much drug absorbed than when we give it to them with hay. We know from my PhD work that when we have horses eating ad libitum hay or unrestricted hay, and we give them omeprazole, some of them have no demonstrable acid suppression at the level of the glandular mucosa. And so you might be given $30-40 worth of omeprazole a day and getting 0 acid suppression where your glandular lesions are. So what that means is it's counterintuitive, but what we actually need to do is fast those horses overnight from about 10 o'clock onwards, fast those horses overnight, and then administer the omeprazole on an empty stomach, let them absorb the drug, and then activate the drug about an hour later, 30 to 60 minutes later. And that gives us a much more effective duration of acid suppression. The other flip of that is if we do that for squamous disease, we can actually use half as much drug. It's quite counterintuitive, and it's quite confronting to say that we have to starve horses overnight because we spend all this time saying that for prevention we have to feed them. But it's recognizing there's a difference between the therapeutic phase and the preventative phase. It's also recognizing that when we look at horses overnight, they spend an awful lot of time not eating. I'll just show you this graphic here. So when we look at, because the moment we tell people to starve their horses overnight, they freak out. But basically what we're looking at here is this is the time that horses spend. The bottom is the time the horses spend eating. The very bottom is eating from their hay net, and then it's foraging. And what we see is about 10 o'clock at night, they go to bed. And they spend a relatively small amount of their time budget, less than 20%, actually foraging and grazing during the night. And then they wake up in the morning, have breakfast, and start eating again. And so what we're actually trying to do with holding them off feed overnight is basically get to them before they have breakfast, so that they've got an empty stomach, so that we can get the drug into them, activate the drug, get maximal effect, and get bang for our buck as well as efficacy.
Yeah,
we do have other options for treating glandular as well, but that's my preferred starting point. But we also will use misoprostol, which is another drug which has a different mechanism of action.
It's interesting. Like I know it is a bit of a mind bender when you tell people to not give their horse ad libitum hay when they're treating it for ulcers, and there's starting to be sort of good recognition that not having access to ad lib forage is one of the biggest risk factors of ulceration. And I think that people find that really, really hard. But I guess in the it's a short term, weird, if you like, kind of thing to do for a long term gain. If you don't do it, then likelihood is that you're going to spend all this money and all this time trying to treat your horse for ulcers, but because you're not giving it that fast period before you actually give it the medication's not going to work. So yes, long term, we're definitely not saying long term don't give them ad lib access to hay. I mean, once you're off that drug and then you move on to the management prevention phase, then ad lib hay is absolutely what you should be giving them, but just for that treatment time to make sure that you get a response, to try and make sure you get a response, keeping them off the hay before they have the medication is really important.
Yeah, so to optimize your chance of getting a positive response and to some degree a return on investment, right? And then when we get to prevention, we swing the other way and we do other things to extend that grazing interval. So when they're off the medication and we're focusing on management and prevention with management, we actually try and drag that period that they eat from 10 o'clock through to 12 o'clock or 1 o'clock. And there's some strategies that we can do to do that. And that decreases the amount of time that they spend fasting overnight and decreases their risk of squamous disease. So we almost swing from one end of the spectrum completely to the other end of the spectrum.
Yeah, and I think I'd really like to talk about the multiple hay nets and using the small hole hay nets and also feeding off the ground. But before we get to that, something that we talked about briefly last night was the potential for acid hypersecretion after they've been on these acid suppressing drugs. So the stomach kind of panicking in a way that it can't produce enough acid, and then when the acid suppressing drugs are removed, then it will hypersecrete acid. Do you want to just talk about that and some of the things that we might be able to do to manage that?
Yeah, so we had someone popped a question up there before about the side effects, or it's probably better to say the possible side effects of omeprazole, because we're only just starting to explore this now. If anyone out there has a nice hefty research budget and wants to send it my way, we can give you some really clear answers in a couple of years. It never hurts to ask, right? The primary thing we worry about is that when we put horses on acid suppression and we remove the acid that's in the stomach, the pH goes up, and so we get a neutral environment. And the horse's body says, "Hey, we need more acid," so it increases the stimulation for acid production. And so the signal for acid production, and we also get proliferation of the cells that regulate acid production. So it's not just a chemical effect, a signaling effect; it's a physical effect. We get proliferation of the cell population. Then what happens is when we stop the acid suppression, the body gets this, it's like someone's turned on 10 light switches at once. You've gone from being in the pitch black and someone's just turned on a whole panel of, big LED lights, and it's like, boom, and you get an exaggerated increase in acid production. And in humans, it's about 20 to 40% of the population that experience this rebound effect, and it manifests as severe heartburn after, a month's omeprazole. So it's a relatively short duration, but high magnitude effect. And it's a real problem in humans because omeprazole or PPIs in general have become so common over the counter that people they're not addicted to them, but they can't get off them, right? Because every time they try and get off them, they get this rebound. And they haven't quite figured out in humans what the best strategy is. So do we see the same thing in horses? We don't know because we haven't really had great look into it. What we do know is that within 2 weeks, we see that upregulation of gastrin, which is the key driver. Gastrin concentration doubles within 2 weeks with normal omeprazole dosing. So the process is going on. We've done some work in racehorses looking at during the withhold period as they take them off drugs to go into racing. And we have some preliminary data that says those horses are rebounding. There's probably a contribution of rebound to them developing severe lesions even by the time they're racing several days later, not weeks later, but days later. And so that's one of the downsides. And then if we put them on it for months and months and months, what happens then? We don't know, but it probably gets worse and worse and worse. So that's a real challenge. The question then is, should we taper them? And again, the answer in human medicine is typically no, unless we have a problem. So I don't routinely taper personally, but if I have a horse that I take off and it bounces, then I'll get it back on and I'll taper it and try and manage it down and, you know, get it through its stage. The advantage we have in horses is that we can play around with that a little bit and really pound the roughage and the lucerne and alfalfa combinations into that transition period and manage them out of that period, because it's a relatively short-lived effect. In humans, it's, you know, only a few days. If you can get through those few days, then you can actually come out the other side and come off the medication with short-term therapy. But if you've been on it for months, then it's a much more upregulated process and takes a lot longer. You might have increased acid suppression for several months after you stop the treatment. So every time you have a glass of wine, you get heartburn. You know, these sorts of things. The other big concern with, sorry, go ahead.
Sorry, Ben. So if a horse has been on, really, from what you're saying, any length of omeprazole treatment longer than a couple of days, then the likelihood is that there will be some acid rebound effect. And so taking them off the drug is a period of time. There's going to be a period of time where people are just going to have to be hyper aware of the fact that that horse's gut is going to be more acid than normal. And so using your alfalfa, using tricks, I think you said last night, which is fascinating, that if horses eat hay off the ground, they chew twice as much and produce.
Yeah, I'm still trying to track down the original research, but I've seen that presented, yeah.
Yeah, so there's that.
Yeah, so it comes down to how much, you know, bicarbonate's going in there. So, and the more they chew, the more bicarbonate they make. So the things that we can do to make them chew more, feed them roughage, not chaff, or grain, not concentrate. Feeding on the ground, they chew twice as much as when you feed it at head height. They're the big couple of things, and feeding multiple sites.
There probably is an argument at that point in time too, if it's possible to take the horse off concentrate feed to get them through that period of acid hypersecretion, because, you know, they chew pellets and concentrate feeds, grain-based feeds, a lot less than what they would chew forage, and then you also get the fermentation of the starch in the stomach that can add to the acid load. So if there is horses that people are struggling with and they're going on and off omeprazole treatment all the time, and you just can't get them out of that cycle, then it's kind of there is an argument for kind of upping the ante on your preventative strategies. And there's also a really good time too, we'll talk about supplements in a little while, but using your buffering type supplements as well, just to give the horses natural buffering. So Ben just mentioned bicarbonate, which is in the saliva. The horse's saliva is naturally buffering, which is why we're so big on feeding a horse a lot of long stem fiber, so that they have to chew a lot. When they chew a lot, they produce a lot of saliva, which it creates a lot of natural buffering in their stomach. But yeah, if it's something that's only just been really started to talk about, you do have a new paper, Ben, that does talk about it a lot, which is a big help to us. But yeah, we'll talk about preventions. But if you're struggling getting a horse off omeprazole, then there's some stuff you can do, I think.
Yeah, and the first thing is make sure the lesions are gone before you try and take it off, because obviously if the lesions have only half healed and you take it off and you get a rebound, that's a recipe for a very cranky stomach. And so, you know, that gastroscopy recheck. Do I scope every horse that's got squamous disease that I treat? Do I rescope them? No, because, you know, if they respond well and they come off and everything's fine and I've changed the management in the meantime, sweet, I'm good to go. But if I have glandular, I always push for a rescope. If I have a horse that comes off and bounces back and clinical signs come straight back, then I want to know, is that a true rebound or is that a non-responder? Is that a horse that never actually got healing? It just got symptomatic relief? Or so did it just get symptomatic relief because of the timing? Like, as I said, so when we talk about acid suppression, and we'll talk about this when we talk about doses and prevention doses, it's the same thing. So when we talk about acid suppression, I'm going to get my hands on the right side of the screen. When we talk about acid suppression, we're talking about going from, you know, a pH of 2 to 7, and we go up from 2 to 7, and then the impact from horse to horse and the impact of dose is not how high we go up. So if we halve the dose, we don't go up half as far. We don't go from 2 to 4. We still get the same magnitude of acid suppression. The difference is the duration within the day. And so it's how long we acid suppress for that is the difference between, say, 4 mg per kg, 2 mg per kg, and 1 mg per kg. And that varies from horse to horse. When we think about that in terms of the difference between symptomatic response and clinical healing, which again goes back to why I would scope these horses, we estimate we need at least 16 hours of acid suppression for healing to occur. Now, if we give our horse omeprazole at 8 o'clock in the morning, 7 o'clock in the morning, if we're eager beavers, and we ride that horse at midday, if that horse only got 6 hours of acid suppression and primarily shows its clinical signs when it's riding, it might be fine when we ride it, but it's got nowhere near enough acid suppression for healing to occur. So we've got symptomatic control, but not healing. And so we have to, we build that into our non-responders. So it's one thing to have our blanket statements for the horses that follow the rules, the 75% of squamous lesions that follow the rules. But when they don't follow the rules, we start getting into very individualized approaches and, working through logistics of each individual, each individual horse as a horse, because they're responding variably within a population.
It's not straightforward. Yes, Em?
Sorry, I just wanted to touch on last night Ben mentioned about the duration that you could expect to treat squamous and glandular ulcers for. So I think that's a really interesting point to cover, Ben.
Yeah, so we talk about, so GastroGuard, which is the global standard, is registered for 28 days. When we look at the data and 14 to 21 days, and the consensus statement recommendation, which was the expert panel that I chaired, was 21 days based on the evidence. So there's a small difference between the recommended dose, the duration, and the label duration and the recommended duration. Now that's still 25% reduction in cost, if nothing else, if we can reduce the duration of therapy, as well as potentially reducing any other concerns we have. Glandular, we always treat for longer. We typically say 4 to 6 weeks. It's a little bit of variability from person to person and place to place, but the recommendation's at 4 to 6 week mark. They are slower to heal, the glandular lesions. But as we start rolling out new generation acid suppressive drugs, which has been what some of my postdoc work was looking at, not my informal postdoc work at least, was looking at newer generation acid suppression, we start to peg that back a little bit too. So when we've got really potent acid suppression, we've brought the glandular back to 4 weeks as well. And the other thing to say is that the bad lesions don't necessarily heal slower than mild lesions. So a grade 4 doesn't take twice as long to heal as a grade 2. If you get acid suppression, the grade 4 squamous lesion will heal beautifully within 2 to 3 weeks. So we don't have to treat bad ones longer. It's more about the location in the stomach that dictates our duration of therapy.
Okay, so we might move on to actual prevention strategies now, and if you want to work in some discussion around supplements as well in amongst this too, but you want to start with prevention strategies for the squamous ulcers?
Yeah, absolutely. So one of the things, and it's a sort of a risk factor / prevention study, one of the things that pops up is, we put horses on pasture as a preventative strategy for ulcers and for specifically for squamous disease. Pasture is not universally protective. And, this is a New Zealand study. And basically in this New Zealand study, they were looking at race horses, and they showed that there was no protective effect of having those horses on pasture. And there's a couple of factors that potentially tie into that. One is that the quality of the New Zealand pasture, very nutritionally dense, but not very fibrous. We get a slosh in the stomach rather than this big firm mat we're looking for. We want a nice structural ball of food in the stomach. So it's counterintuitive, but one of the things that we think about doing is in horses that are either otherwise at high risk because of their exercise load, like these horses, their carbohydrate load, or horses with recurrent problems, i.e. they've had ulcers and they keep getting them back, is that we actually feed those horses who are on amazing pasture hay. And then we actually feed them moderate nutritional or low nutritional quality hay to bulk out their diet. And so I think that's a really important thing. It's getting enough roughage into the horse. What's enough? We generally say a minimum of 1.5% body weight. And and the other thing that ties in here, which is similar to the pasture analogy, is that over the years we started, when we figured out that alfalfa, lucerne hay had a lot of buffering capacity, it became really popular to feed for prevention of ulcers. The limitation of that is that it's so nutritionally dense that we can only feed small amounts of it. And so we got into this situation that horses were getting fed their roughage, a few flakes or biscuits of a couple of flakes of biscuits in the morning, a couple of flakes of biscuit in the afternoon, and they're nowhere near their 1.5% quantity, let alone the roughage stem that we're looking for. And then and I'll pass back to you in a bit to talk about the other impacts of overfeeding that in a diet. So from a stomach point of view, what we actually want those horses to be doing is eating a good, well-manufactured hay, but low nutritional quality or medium nutritional quality to get bulk. And then we top up on that with strategies like using the lucerne alfalfa hay and supplement feeding and stuff like that as they need. The next thing that follows from that also relates to that particular study is they exercise those horses, being race horses, first thing in the morning. And we know that because horses naturally fast overnight, and I'll get you to show you a bottle example because it's such a good example. When they fast overnight, they don't have anything in their stomach and the acid splashes around really easily. So when we exercise horses in the morning, all else being equal, the risk of squamous disease is much, much higher than when we exercise horses in the afternoon. And so a very simple thing we can do is just change the time at which we exercise horses. Now, race horses are a particular challenge, but when we talk about riding horses, horses are going to consume 70%, maybe even more of their roughage intake during their daylight hours. So if we're exercising them in the afternoon, then they've got a lot less acid. So they've got a lot more roughage in their stomach to protect that acid from splashing up. We can supplement that further by being very strategic by feeding them hay immediately before we exercise them. And so feeding a biscuit or a flake or two of lucerne alfalfa hay on the ground while we tack them up will, particularly important in the morning because we need to get that buffer in there, then will increase our buffering load in the stomach and will also increase our roughage in the stomach and our physical stratification. Then we reduce our carbohydrate. And then the last thing we try and do is reduce our quantity of exercise. So we focus on quality of exercise, not duration of exercise. So not necessarily high intensity, because not every, dressage horses don't necessarily need to do high intensity workouts. But what we don't do is, spend 45 minutes warming them up, jump them for 10 minutes and 45 minutes cooling them down, because that's very insulting to the stomach. So in prone horses, we try and bring that window down and really focus on the quality, not the quantity.
Yeah. Okay. And if, I guess, I know, I grew up on a beef cattle farm and our horses could do 40, 50 Ks in a day and be going for 12 hours sort of thing. And I cringe now thinking about how little we fed them during a day, like a full day of work. And I know, like, looking back at my mare's behaviour, like, she would have had we scoped it, she would have had ulcers, but we didn't even know. I didn't even know it was a thing back then. But, it's not possible for everyone to ride in those short periods of time. Endurance is a classic one. Like, you cannot get an endurance horse fit unless you're doing a lot of kilometres on it over a long period of time. But I guess for those horses, making sure that they start out with a stomach full of buffering hay, so your alfalfa or lucerne is good for that. And then where possible, making sure they get access to water, because not being off water is a high risk factor for ulceration, according to some studies. So, every opportunity to give them a drink. And if you can, if I'm out for hours on a ride, which is not uncommon for me, we'll just stop and let the horses graze for a period of time on whatever pasture is available. Generally, it's not very lush pasture, but just trying to keep some level of fibre and saliva going down into their stomach over the time that you're riding them will help more than going out for hours at a time and not letting them have anything to eat.
Yeah, and we're taught, don't let the horse graze with a bit in its mouth. It's, at least from the stomach point of view, it's not a great thing for it. Let it have a snack. If you're parked up watching something happen for a while, just let the horse put its head down and graze. They're all things that are going to be beneficial.
So I'll show you the Ben mentioned bottles, and a lot of you probably have seen my milk bottles, but I mean, for me, from a nutrition perspective, one of the biggest things that Ben has already mentioned is before you ride your horse, give it a feed of hay and loosen hay if possible. Sam, I don't know whether you can locate there's an article on our website that's got the little graphic of how much hay to feed before you ride, just depending on what the horse has been doing and when its last meal was. But I kind of use these milk bottles as a model of a horse's stomach, and they do a reasonably good job. Very cheap model of a horse's stomach, but this one with no fibre in it sort of signifies what an empty horse's stomach might look like. It's got an accumulation of acid down the bottom, and it really doesn't take very much to get that acid to move up to the top part. And I think another thing that's really interesting too to remember, and we were talking about this the other day, Ben, is a horse's stomach doesn't actually stay inflated when it's empty. It kind of collapses down on itself. So I can't make my milk bottle collapse, but you can imagine if it did collapse, it would just sort of squeeze all the acid up onto that squamous tissue and burn holes in it. And then my other milk bottle, I usually bribe my kids and pay them about $2 to fill it up with loosened chaff for me, because it's a very tedious job. But this one's got the same amount of fluid sitting down in the bottom there, but it's full of fibre, and I can shake that one as hard as I like, and there's no way I can get the acid to come up to the top part of the stomach. So it's just a visual for why it's really important to have your horse's stomach full when you ride, and ideally, you know, the other big thing for squamous disease is just trying to keep that stomach as full as of fibre and saliva as possible, which, you know, is another big tip for prevention on the squamous ulcers is having your horse's diet as forage-based as possible. So the more you can get away with having that horse on a forage-based diet and using as little concentrate feed as you can, the lower the risk of gastric ulcers. And I'll just add my third prevention is just making sure the diet's balanced, which is what we are all about at FeedXL, is just giving you an easy way to actually make sure your horse's diet is balanced. But something like a zinc deficiency, which is one of the most common deficiencies we will see in horses' diets, and particularly in forage-based diets. So, you know, you can move towards a forage-based diet as an ulcer prevention, but you're going to actually create, if you're not on top of things, another risk factor. But if a horse is zinc deficient, as an example, if it gets a little bit of damage in its stomach, so part of the stomach lining gets damaged, a zinc deficient horse isn't able to heal that very effectively. So you'll get a small amount of damage, and then if it can't be healed very well, then it can potentially turn into a large amount of damage. Or if you've got a horse on ulcer medication and your horse is zinc deficient, then the ability of that horse to heal those wounds is actually going to be quite limited. So making sure that the diet is balanced and you've got nutrients like zinc, and also really good quality protein, because the horse, well, this is more for glandular disease, but the horse creates mucus to protect its glandular tissue, and if it doesn't have the right protein to produce that mucus, then it simply can't produce that mucus, and then it potentially leaves itself more exposed or more at risk of glandular disease. But you might want to cover glandular disease, Ben, because I don't think you've done that yet.
Yeah, so the next question is, you know, that's all about preventing squamous disease, and it's important for squamous disease. It's important for general GI health. We don't have any evidence that it's going to have any direct impact on glandular disease, although, you know, micronutrients and general health are obviously going to be important to healing. But the important thing is we can do all of that and still be at quite significant risk of glandular disease. And so we need to think about glandular disease as a separate entity. And so when we think about glandular disease, the big risk factors are, the biggest risk factors actually being a warm blood. So, you know, warm bloods have a much higher risk of glandular disease. We don't know whether that's a genetic thing, whether it's a genetic predisposition, or whether it's to do with the way that it's a behavioral thing, because the next thing that we see related to glandular disease is it's much more a disease of stress. So we've talked about stress and ulcers for years, but actually it's largely irrelevant for squamous disease. Squamous disease probably causes stress, but stress doesn't cause squamous disease. Whereas for glandular disease, we have a reasonable body of evidence that says that horses that are either stressier or have increased stress response or behavioral stresses are related to an increased risk of disease. And so it could be that the warm bloods are just naturally more sensitive, and they do tend to be naturally more sensitive, and therefore more prone because of their the sensitivity to behavioral stress. And We don't know where thoroughbreds fit in, but I think, you know, the off-the-track thoroughbred sort of has the full spectrum. It can be as laid back and behaviorally unstressful as a cold blood, like Ira's fin horses, or it can be at the other end of the scale and be like any, you know, sort of highly strung warm blood. And I think where you fit on that scale is going to have an impact. So it's that behavioral response and it's that behavioral stress. So the other things that we see are things like in those horses is increased number of riders, increased number of handlers is a risk factor. So it's relatively easy to think if we're a dressage horse, our whole world is about release and moving away from an aid or moving in a certain way to get the aid taken off. If we change riders and you're a really well-trained dressage horse, you're just looking for someone to press the button and do your thing. And if a person keeps pressing the wrong button, you could easily see how that could be behaviorally stressful for a horse. And so, you know, changing riders on some horses or having multiple riders on some horses is going to be behaviorally stressful. Handlers is the same thing. It's this whole human-horse interaction that we, you know, as veterinarians tend to sort of look past, but there's a real impact of that behavioral human-horse interaction. Exercise does play a role, but it's a different relationship. It's not the duration of exercise, it's the number of days we exercise per week. And so we know that horses that exercise 5, 6, 7 days per week are much greater risk of glandular disease than horses that exercise 4 or 5 days a week or less, irrespective of the intensity and duration. It's the number of days, or more, probably looked at another way, it's the absence of rest days. And so one of the cornerstone recommendations we have for glandular disease is to build in at least 2 and ideally 3 complete rest days per week into the horse's schedule to reduce the risk of glandular disease. The next thing we look at is the potential of concurrent things like orthopedic pain, saddle pain, back pain to be contributors to behavioral stress and to potentially worsen, you know, the risk of glandular disease. So we always want to make sure we treat the whole horse and not just the stomach of the horse, particularly when we're managing sport horse populations. And then the last thing, which is we don't have a lot of evidence for, but I'm personally a big believer in, is how we manage horses. And one of the things we know about horses is they'll put up with just about anything if they have a friend. If they have companionship and a stable buddy or a pasture buddy, their tolerance for adverse interventions is so much higher. And so having horses pastured together, and then we get really into dangerous territory when we say we should take their rugs off and we should allow them to mutually groom and engage in normal behavior. But for me, I think that they're really important things for horse welfare overall. And I think that they're things that will make a difference overall to our risk of glandular disease in a population. Once we've got all that squared away, then we're in a good place, I think, to talk about supplements. Because if we just do none of that, and you use the example of trying to put a house fire out with a garden hose, which is a great example. If we don't deal with all that background push for disease, then the garden hose isn't going to do much. So we need to holistically manage the horse. We need to bring it back, the risk to as small as we can, and then we're in a good place to talk about supplements. And so when we're talking about supplements, you know, one of the things that I'm looking for in a supplement, basically, I'm looking for a supplement that's manufactured by a company with high quality and high ethics. That the supplement market's largely unregulated or is unregulated. And I think brand integrity and product integrity are really, really important. I really dislike the promise, what I call a promise in a bucket. That people just promise everything, they've got no data, and that this product will cure everything. If it cured everything, we wouldn't be giving it to horses, we'd be taking it ourselves, right? And that someone would be making billions off it because, you know, it's that good. And then the other thing that we're looking for is evidence, you know, to support the use of the product, and ideally evidence from a product that is, or from a study that's looking at the product in a real world population. So we can, you know, sometimes we have to use evidence from other species like laboratory animals or stuff like that. Sometimes we use evidence from humans, which are basically laboratory animals for veterinarians. Sometimes we can use experimental studies, and the big one that's been popular in the horse world is the the starvation model, use intermittent starvation to induce squamous disease. But ideally, we take them and we look at horses in real life, real world populations. And so I was involved a few years ago in a study that was looking at this, and we were trying to sort of look at a combination of gut health in terms of stomach health and in terms of hindgut health. And what we were looking at here was a pectin lecithin complex, yeast, brewer's yeast, a very specific strain of yeast, and that's really for the hindgut, and that's a different story for another day. And then a buffer, the magnesium hydroxide as a buffer. And what we know is that those coating agents like the pectin lecithin aren't super effective by themselves, and what we know is that buffers aren't super effective by themselves. Buffers are quite good for managing clinical signs, and buffers are quite good for strategic use, the same way we use strategic feeding prior to exercise to reduce risk and to manage clinical signs, but they're not good they don't stay around long enough to have a really significant effect on mucosal pH, not necessarily intragastric pH, but mucosal pH. So what I think we have when we combine those two is we create an alkaline slime. So we've got a coating agent, and then we put the buffer in it, and we end up with this alkaline slime, and that mirrors the normal protective mechanism of the glandular mucosa particularly, and provides a coat that persists beyond the ability to suppress acid in the stomach. These are not about, the buffer for me is not about suppressing acid in the stomach per se, it's about creating this alkaline slime. So you need the combination of two. So we did this study a few years ago, and this was looking at a population of horses. It was a thoroughbred racehorse population, most of whom had ulcers, had been treated for their ulcers, had largely resolved, and then we took them off and we followed them over the next 28 days on the treatment or on a placebo. And when we look at the squamous, what we saw was on the placebo, nice little cluster here, and they got worse. And that's not a surprise, right? We knew that that's the case. And in fact, they went back to exactly their baseline for that population. 75% of the horses got their lesions back in a month, because we didn't change any management or anything else in this study. When we look at the supplement, what we saw is that they didn't get worse, and if anything, they actually got slightly better. So we were able to blunten that rebound that we saw coming off omeprazole, and we were able to blunten that redevelopment of disease. And in fact, we had some beneficial effects there as well. And that was pretty cool at the time. But for me, it wasn't that exciting, because I've always considered squamous a disease of management, and if we can manage it out, then supplements and drugs become less important. Where it got kind of cool was when we looked at glandular disease, we saw, again, the placebo worsened, and again, back to their baseline, back to about 62.5% in this study. And that's the first study, it's actually, I think, the only study that's actually published glandular recurrence. And what it says is that they can recur very quickly in that rate, particularly in that population. And same thing that we saw with the squamous was we saw that the glandular didn't worsen, and in fact, on average, they got better. It wasn't a statistically significant effect, but overall, we had a decrease in lesions. So for me, when we talk about supplements, that's what I'm looking for. I'm looking for quality manufacturing, high quality company. I'm looking for good quality scientific evidence, and there are varying levels of that, and it's not all or nothing. And I'm looking for, in a product, I'm looking for the combination of coating agent and buffer. And I use that as a cornerstone in virtually all of my patients that I treat. Coming off, I look to have them on something like that, if nothing else, just through that management period, through that management period of coming out of treatment into the long-term phase. And in the middle, we're trying to fix the nutrition, and we're trying to fix all of those other risk factors as best we can.
Yeah. So, I mean, the post-omeprazole treatment period would be a really good time to be considering using a supplement. Like, as long as you've got, like you said, you're not trying to put out a house fire with a garden hose, but you've got like your management under control, just trying to get them through that period where they likely are hypersecreting acid, and giving them extra help with coating their stomach, buffering the stomach fluids. A good time to be considering using some of these supplements.
Yeah, and it depends on where you started, right? So if you start with a horse with lots of identifiable risk factors, particularly for squamous disease, and you're going to treat it, and you can identify and fix those risk factors, then your need for long-term supplements quite low, because you can probably manage those risk factors out. Glandular disease already brings us down here because it's just a bit more variable. And then we see these horses with glandular disease that have no identifiable risk factors and significant glandular disease. And they're horses that, we put on supplements, and we keep them on supplements because if we can get them back to baseline and we can get them back to comfortable, then we keep them there. And what we'll see with some of those horses is they're great while they're at home, and then they go away to competition and they flare and they have, you know, their little issue at competition. And those horses I will treat intermittently with omeprazole, but I categorically do not use omeprazole for the long-term management of glandular disease, and I will use it for squamous disease, but only after I've got these other pieces in place and there's a clear need for it, rather than just as the go-to, as the first go-to. There's other things we should be doing well before we put horses on long-term medication of anything, really.
Okay, so Amanda's asked a question here. Was quite a long way back, saying, when travelling long distance to a comp and competing for 10 days, what do you recommend to prevent ulcers? So omeprazole, carafate, Protexin. I'm going to say not probiotic. There's no evidence in horses that a lactic acid bacteria probiotic would be protective, particularly in gastric ulceration. But yeah, I'll let you answer on the other ones.
Yeah, there is one study that just came out relatively recently that looked at it's a particular strain. I think it's Cerevisiae boulardii. I have to check the strain. That did have some protective effects against squamous disease. And so, but I agree. I mean, the probiotic's not going to be the cornerstone of how we manage gastric disease risk. Now, probiotics are...
Be really careful making the distinction between your yeast probiotic and the bacterial probiotic, though, because there is evidence in horses that the yeast probiotics can be effective for certain things, but the lactic acid bacteria probiotics, there's little, if any, evidence for anything.
Yeah, sorry, good clarification, because, yeah, no, absolutely. The lactic acid, there's very little evidence for them for anything, really. And there are studies that, for example, in foals, where they actually increase the risk of disease. So they are not universally safe. So, and the yeast ones, so the yeast ones probably play more of a role, but the majority of the time that we're using the yeast is we're really thinking primarily about the hindgut, but there are some specific places where we may have them targeting stomach health as well. And so back to the question about the horse that travels for 10 days, it's going to vary from horse to horse. So we have a range of horses here. All of them we try to optimize their management. And then from there, in terms of feeding, we then look at them and say, okay, what's their risk of disease? What's their history of disease? I've got one of my own personal horses, very long history of glandular disease. And so he's on a supplement that's based on what I just showed you. And that's his baseline. And he does well on that in general. But then we're about to go on the road for 3 or 4 weeks, play back-to-back competitions. And if he flares during that period of time, then I'll put him on, an acid suppressor on top of that. I'll put him on omeprazole on top of that. If he did that every time I went away, I would just be proactive about it and say, you know what, Friday before I leave, Friday morning, he gets his dose of omeprazole. He gets it Friday, Saturday, Sunday, comes home, and as long as he eats his food on Monday morning, he doesn't need it anymore, and treat them individually. So there's certainly not a problem with treating horses, what I call pulse therapy, but probably intermittent therapy is maybe a better term. The other thing that's interesting, that didn't come up yesterday, and it didn't dawn on me, but I remembered it sort of earlier, was when we talk about these horses that travel a lot, they actually, international level horses, there's a study looking at show jumpers, and international level horses had less glandular disease than national level horses. And being a national, it was actually a reduced risk factor. So you were less likely to have disease if you're an international horse. Now, there's a couple of things that might mean. It might be a performance limiting effect, which is the horses at national level that have ulcers just can't go that next step and don't make it to the top. The other possibility, and we have evidence from racehorses that says poor performance is related to glandular disease. But the other possibility is, if it's behavioral, is that it's an adaptable thing. And so when we look at horses that professional show horses, they live on the road and they're highly adapted to it. It's actually not that stressful for them. It's their life. They just got used to it. It's like pre-COVID jumping on planes. We were all used to it. But if we take the average Joe who never travels and stick them on a plane every 3 days and send them around the world, then it's going to be you know, it's going to be stressful. So I think we see the same thing with our horses. So some of those horses will adapt. So I wouldn't routinely do it unless there was a specific problem. But if there's a specific problem, I'm going to start with baseline nutrition. I'm going to look at a quality supplement, and I'm going to escalate then to using omeprazole strategically to manage clinical signs around competition, and also use things like the marine calcium carbonate products and those sorts of things to manage risk around competition. I think that answers that question. Ira, you've been very quiet there. Do you have any questions?
I
Or
have.
we start going through the board.
I'm looking at the questions, but you guys are picking up and answering them as they come. I do want to, there's been questions asked about aloe vera a couple times, just to get the answer out there and your thoughts on that.
Yeah, so there's a publication looking at aloe vera. It was done in Adelaide, actually. They had some positive effects on squamous disease. I don't think we should be using any of our supplements as the primary means of treatment. I think when we're talking about treatment, we need to, you know, that omeprazole and our pharmacological management is a cornerstone of what we've done for years and needs to stay a cornerstone. I think aloe vera is probably better at maybe relieving clinical signs than it is of true prevention. And it's not my go-to, and probably maybe in many ways I'd say the same thing for a lot of supplements. I have a preferred go-to. This is what I go to, and I go to that for the reasons that I've outlined. If I talk to someone and someone says, hey, I've got my horse has had all these problems, and I've got my horse on aloe vera and it's doing great, I'm like, sweet, awesome. We don't need to argue with that. So, you know, some of it's that individual response, some of it's that there's a lot of inter-individual variability. So, but the reason I choose the products that I choose is because of consistency and predictability of response, and they're more likely to be effective across a population. They're also not universally effective, but they're more likely to be effective in my hands. I know we've been a little bit vague about not saying brand names, but we're not allowed to. So we're just going to have to work within that limitation. I know everyone wants the names of what we're talking about, but we're just going to have to work within that limitation. It's killing me too, don't worry.
Hey, can you guys hear me?
Yep.
Can you see me?
Yep.
I can't see you anymore. Anyway, no, sitting here chatting to myself. I just want to say we have covered like the biggest part of what we wanted to talk about today. So what we'll do now is just go on and answer questions. So if you have to leave, don't feel bad about leaving. We understand people have got other things to do other than to hear and listen to us talking about ulcers. Would love for you to jump on the polls and just answer the poll questions for us if you can. But yeah, if you want to stay around, we'll answer some more questions. And Ben, Linda's brought up a really interesting point here, and it's not something that I've put together yet, but I'm not thinking about it in terms of squamous and glandular, but she says if gut bacteria can determine behavior, then it makes sense it has to be part of the management for glandular ulcer prevention. So I guess this is where we start to bring the hindgut into the conversation and really recognize that if we've got a messed up hindgut, then likelihood is that the horse's behavior is going to be out of whack, because one of the things we know is that when a horse's hindgut gets disturbed, their behavior will change. So I wonder how much that plays into their predisposition to glandular ulcers.
Yeah, and then it also ties into what impact, you know, omeprazole and those are having. I do want to just pick up on one other set of questions because there was a chain there at one stage. You know, just giving horses bicarbonate and these buffers that we feed them orally put them at risk of rebound, and the answer is no. We're not getting enough acid suppression. You know, we're not getting enough blocking of acid production or removal of pH in the stomach to increase that risk. So there's very little downside associated with those buffers. The biggest one is that most of them are incredibly short acting. Like bicarbonate really is incredibly short acting, as in minutes before it disappears in the horse's stomach, which is why we need to constantly flow it in with saliva and eating. When we think about the bacteria, it goes back to one of the questions is why do we talk so much about ulcers? And I think there's three reasons why we talk so much about ulcers. One is they are a very important disease. Two, we can see them. You know, the whole thing about ulcers kicked off when we actually started looking in horses' stomachs and endoscoping. They'd been there forever, but the actual whole medical thing of it. And three, we can do something about them. You know, we have a good pharmacological intervention. So disease awareness breeds out of those three factors. When we go to the hindgut, it's important, which we're starting to increasingly recognize. We can't see it, and we're not very good about knowing what to do about it. So we're sort of 20 years behind in the hindgut as to where we were in the foregut. And then Nerida and I had this conversation the other day. No one ever talks about the small intestine, but there's 22 meters of small intestine and it joins one end to the other end. Surely it's got to be important in terms of what's going on in bacterial populations and health. And we know from experimental species it is, and we know from humans it is. We just ignore it in the horse because it's inconvenient. It's an inconvenient truth. So do the bacteria have a role in glandular disease? First thing to say is we have no evidence, and we have evidence that says it doesn't exist. There's no link that we know of between Helicobacter, which is one of the primary causes in people, and glandular disease in horses. So that's out. Would other bacteria, would dysbiosis potentially play a role? Yes, and we have some evidence that says that the bacterial populations in ulcers and around ulcers, glandular ulcers, is different from normal horses and diseased horses. So something is going on. What we don't know is it cause or effect? And then from there, we can just get into a whole string of don't knows. We pull it all the way back to saying, well, even if we know about it, what can we do about it? And it goes back to nutrition. It goes back to the cornerstone of healthy guts are nutrition. And then other things on top of that, like some of these particularly probiotic yeasts and these sorts of things that we use to manage hindgut disease.
Yeah. But I think from what you're saying, you know, if the number of handlers and different riders is having an impact on a dressage horse, I mean, a dressage horse that's got dysbiosis in its hindgut, so an unbalanced number of fibre fermenters versus sugar and starch fermenters, which is reasonably common with the way the modern day horses are fed, that's going to exacerbate that stress because those fibre fermenters are the ones that produce things like dopamine, which, you know, you don't have enough of hormones like that, then you probably are going to be more predisposed to getting upset about small changes in the routine compared to if your gut was healthy. It's a little bit like a tired toddler. Aya and Sam, you get a tired toddler and the smallest little thing can set them off, whereas, you know, when they're well rested, they're much more robust. I think it's the same with the hindgut. If the hindgut is healthy, horses tend to be a little bit more robust and a lot more accepting of things, whereas if that's out of whack, then their behavior does change.
Yeah, absolutely. And it's threshold effect, right? It's you know, resilience, threshold effect, and those sorts of things. So we're getting better at it. Like we've now got tools that are quite good at looking at microbiota, and so we've got the technology now. What we still have limitations with accessibility. So now we're getting really technical, but there's a really cool study that just came out that showed, so for a long time we've just taken fecal microbiota for the last 5 years and we've used that. There was a really cool study that came out recently that said, actually, if you want to know what's going on in the colon, not only do you have to take the feces from the colon, but you have to take it from the very specific part of the colon that you're interested in. So that the front half of the back half of the colon have completely different bacterial populations. So what that means is we have to do post-mortem studies. And so if we talk about doing a relatively modest study with this new technology, we're talking $20,000 to $50,000 just to analyze the samples and get the statistics done. We very quickly run 50, 100 grand to run a relatively basic study. And that's the big limitation we have at the moment. And the back end of that is that there's no heavy commercial drive for it. So for gastric ulcers, there was a lot of commercial drive, which is not always a bad thing, because it gave us a lot of information, a lot of knowledge about the disease, because there was a solution for it. There was a pharmacological solution. The hindgut's going to be much harder to unravel because we're going to have to find money from somewhere else. It's a lot more money because it's so much easier to look at the stomach than it is the hindgut. But we'll get there.
Yeah.
There are ways we can do it,
Yeah.
and we'll get there.
And I think too, just I mean, the easiest thing to remember for everyone is just feed a horse like it is a horse. Lots and lots of forage. If you're going to use grain, make sure, please, that it's cooked grain so that starch gets digested in the small intestine, doesn't end up in the hindgut. I mean, there are two big things you can do to keep the hindgut in what we would assume is going to be a healthy state, and then trying to get a variety of fibre in there as well is an important one. Ben, I just want to point out there's a good comment here from Steph saying, thanks, Ben, and all. This has been great. The take-home message I got from Ben is that we should all be drinking red wine.
Yeah, little bit.
So good job. Good job on that one. Yeah, a little bit, not 2 or 3 bottles. Roseanne saying half a job, laughing if you won't help with your go-to, Ben. Clues, ingredients to look for. Roseanne, what we might do, just because with Feed Excel we're unbiased, we don't recommend ingredients, and the whole point of Feed Excel is giving you guys the tools to actually make your own feeding choices and to pull you away from all this marketing that gets thrown at you. And give you the education you need to figure out what's best. But what we can do is actually write you a document and do summarise. We'll give you some background on some of the ingredients that are used in some of these supplements, so that you then got a little bit more information to go and read labels and make your own choices around that stuff. There's a few other people I can see, Carrie, asking the same thing. Linda also saying research grants. Have you picked up any other good questions, Sam or Avery? That
I have one that I actually received before the masterclass, and I would love to ask it just because she should be here, I think, Suzanne. It's regarding omeprazole and giving it orally versus injections. This was asked yesterday as well, but just to get Ben, your opinion about this.
Yeah, so there's some really geographical differences here. So for those of us in Australia, we have some products available that aren't available yet elsewhere. Australia and the UK particularly has a specific formulation of long-acting injectable omeprazole. There are some formulations in the US that are different, so they're not the same formulation at least. The first thing to say is that we're talking about unregistered medications. It's the same when we're talking about sucralfate. It's the same when we talk about misoprostol. They're unregistered medications, and they need to be used appropriately within frameworks, and they need to be used, like all medications, with appropriate veterinary guidance. The advantages that we see with the newer generation drugs is that we get much better acid suppression. And one of the particular advantages we see with this new generation injectable formulation is that it bypasses that variability of drug absorption between individuals. And so we get a much more consistent effect, and we also get a much more sustained effect because it's a very sort of slow release product. So we get this long sustained effect, whereas our oral drug comes and goes very quickly each day. It sort of has this cycle like this. And the original preliminary work we did was looking at this particular formulation, and this is published. The original preliminary work that we did was that we were able to move in that population of racehorses that I've done a lot of my work with. Oral omeprazole alone only gives us about a 25% healing rate for glandular disease over a 4-week period. When we moved to the newer generation injectable formulation, we got that up to 75% over 2 weeks. So there was a dramatic, it was a small study, but there was a dramatic shift in our ability to treat glandular disease. And what that tells us is we need more potent acid suppression to treat glandular disease than we can sometimes achieve with the oral formulations. But it reinforces the need for us to use that oral formulations as effectively as we can, using that overnight fasting periods and then feeding them 30 to 60 minutes after administration. We've also looked at some of the newer generation oral medications, or at least one, which is esomeprazole, which is marketed in human medicine as Nexium. And the advantages of esomeprazole in humans are that it's a more consistent effect, so we have less variability between individuals, and so we get a more consistent effect, and it's more potent, so we get a greater effect for the same dose, or for even, it's about 4 times more potent, so we can use half the dose and get twice the effect. And we've done some work in that, looking at acid suppression through some of my postdoc work, and it's also a product I think that's got genuine long-term feasibility. So these are products that are in the pipeline for global supply. They are available under specific conditions in certain countries, but they're very exciting because I think that they change the landscape a little bit of our ability to manage glandular disease. Because the whole reason I got involved in this whole thing anyway was I was frustrated with treating horses with glandular disease, spending €50 a day on medication and having them come back 6 weeks later and have 70% of them still had lesions or 50% of them still had ulcers. And so my whole research path stemmed out of that, was inherently a frustration of we had squamous largely solved at that point, but we weren't getting a grip on glandular lesions. And so, I just sort of took it upon myself and stuck my head down and said, well, this is what I'm going to do research-wise to try and see if we can start answering these questions. And there's been a bunch of other people do the same thing. So we're starting to put together a much better strategy for that. And it's starting to be now, 10, 15 years on, saying, well, we're getting a grip on this. We're starting to actually have meaningful conversations about how we can manage this. And the new generation drugs are going to be part of that. But in the interim, we still use the drugs we've got as well as we can.
Okay. Ben, there's just a question here. Debbie, what's a buffer? Sorry, Debbie, we should have defined this. We get so used to talking about these things and forget to define them. But my very simplistic way of thinking about a buffer is if the acid being secreted into a horse's stomach is pH 1 or 2, Ben, if we add a buffer to that, it will make that acid less acidic. It's not the chemical definition of what a buffer is, but if the horse they've got natural buffer in their saliva, so when saliva goes in and mixes with that pH 1 or 2 hydrochloric acid in the horse's stomach, it might be pH 3 or 4. Is that accurate, Ben? So it raises the pH, makes it less acidic and less burning. So the horse has got natural buffer. Lucerne hay or alfalfa hay is also a natural buffer. It's a buffering forage, and then we can use buffers like your marine source calcium, magnesium hydroxide is a really good one. So we can actually add buffers in supplements to just bring the pH of the fluid that's splashing around in your horse's stomach up, so that it doesn't do so much damage if it comes into contact with that squamous mucosa.
Yeah, it's something that soaks up acid, is the way I look at it. And when we think about pH, it's also, so that's the very simple version, then we get slightly more complex. When we think about pH and when we look at buffers and we actually measure the fluid in the stomach, they're not terribly effective. The horses have such a pronounced ability to make acid that the amount we put in there is only modestly effective. So, in humans, we use Gaviscon or Malox and these sorts of things. So the cornerstone, you get heartburn, you just take some Malox and you're good to go for another couple of hours and a couple more glasses of wine. But they don't work like that in horses. But what I think we do get, as I said before, is if we combine them with the coating agents, the pectin lecithin coating agents, what I think we get is we still don't change the pH of the fluid swishing around, but for the glandular mucosa, we change the slime. We make the slime better, and the slime's only a couple of millimeters thick, but that's all it needs to be to protect the mucosa of the glandula is actually 7, and the inside of the stomach might be 1, and this incredibly small layer of slime is able to buffer that and able to protect that acid. So it forms a protective mechanism. And so again, the coating agents and the buffers are going to be more effective at that than just the buffers. What the buffers can be quite useful for is management of clinical signs. So, if the horse only has a problem when it's being ridden, give it before you ride it. And then the same way we use strategic feeding to give prior to exercise to reduce the squamous of disease. Because even if they only last for a short duration, as long as they last for the period you're riding, then they're going to have a positive effect.
And thanks, Sam. I just saw that you had actually answered that question about buffering. So we will finish up very soon. We might just answer one or two more questions and then we'll leave it there. I did put an invite and a link to our FeedXL Facebook group. So if you do have questions, you're so welcome over there. You don't need to be a FeedXL member to be part of our group. It's a really lovely group. We're all very polite to one another, and Sam, Aya and I are all in there regularly answering questions, and there is also a bunch of knowledge. We had someone after a Facebook Live I did earlier this week, someone had asked about a sport horse mare that was lactating, not in foal, had never had a foal, but she'd started lactating, and I suggested she go in the group and ask the question there, and there was someone who had done research on that specific problem in humans. So it's pretty amazing the amount of knowledge that we've amassed in that group. So if you've got questions, I know there's a heap of people that have got questions we haven't answered today. If you do have questions and you want to follow up on them with us, join that group and put your question in there, and we'll get back to you. If we need to grab Ben to answer some of the questions, we'll do that as well. So have you got any, Ira or Sam, that are good questions that we can, just two more questions, I reckon. And you want to say?
Sam, do you have some?
Oh, sorry.
And I was just going to put my contact details up there. I'm certainly happy to, help with general advice and those sorts of things. I do put the qualifier that if we're talking about a specific horse that's, when we're talking about specific medications and treatment, that, that's something that needs to be done in conjunction with your veterinarian, both for legal reasons and professional courtesy reasons, because it's the right thing to do. But more than happy to do that. I do consult to vets here, there and everywhere, primarily on the difficult cases, the ones that, the ones that all go fine, they're easy. Or they're not easy, but everyone's got a good grasp on them. It's the ones that, you run into a brick wall for one reason or another. So, but yeah, I'm certainly happy to be contacted, about those sorts of things there. So, and my email's there for you for that purpose.
Yeah, that's awesome. Thanks, Ben. Okay, two more questions, and then we'll call it a day.
You go, Ira.
I think I got all the answered ones that I wrote down.
Okay, so there's one question here from Linda, and she asks, I can't find it now, but I think I've got the gist of it. Does the microbial populations in the stomach affect, or are they different for horses that have ulcers versus don't have ulcers?
So they are different. We just don't know whether it's cause or effect. So there's so many, when we see these associations, we have to separate association from causation. And so they're the sorts of things we're starting to work through. And one of the questions I think that came up was about omeprazole and bacteria. We know that from what we've looked at, that short duration omeprazole may alter the bacteria in the stomach, but it doesn't appear to alter the bacteria in the feces, at least. Recognizing that that's not necessarily completely representative of the hindgut for the reasons we just talked about. So, we don't have a lot of concerns over, I think it's really important to state, we don't have a lot of concerns over short duration targeted therapy of omeprazole in terms of safety, apart from maybe rebound, which we see in some horses. The bigger concern is when we see horses on omeprazole for really extended periods of time where we potentially see decreased efficacy. But we also, and we don't have data on this yet, it's something that we want to look at, is, the impact on the microbiota of the hindgut of long-term therapy might be very different from short-term therapy. And it's, for me, it's the long-term therapy that I think we need to take a little bit of a look in the mirror about and take a step back and focus on these other things rather than just use it as our go-to crutch for managing what is unquestionably a significant and real problem.
I found a question, Ira, if you don't have one.
Yeah, go ahead.
Okay, so there's Tamara is saying, I have horses that aren't exercised vigorously. There are 6-hour spans. They don't have hay or pasture. Is that drastically increasing their chance of ulcers? I feed them over 25 pounds, which is around 11, just over 11 kilos of hay for those of us that speak in kilograms, and 809. They're 809 pounds, so 366 kilos. So they're only reasonably small. I use porter greys as slow feeders. So this is such a common situation for so many of us, particularly those of us that have got really good doers that tend to get too fat, and we are constantly trying to restrict their feed. So how do you feel about that 6-hour time period, Ben? Is it going to drastically increase their risk?
So I'm just trying to. They aren't exercise vigorously. That's what I was just checking that. So what I can show you here is, let me just pull this one up. We have a slide on this. So we know that increasing that time between meals, sort of past 4 to 6 hours, starts to increase their risk of squamous disease. It's probably not going to make a difference to their risk of glandular disease, but it's going to start increasing their risk of squamous disease. And sorry, when I get my slide to show what we want, this one we have at the top right hand here is what we're looking at. If you look at the black line along the bottom, this is again horses tracking overnight and watching their behavior. So the hours aren't the hours of the day, the hours are the hours since 8 o'clock in the morning. And as we see, from midnight through till 4 a.m. and the wee hours of the morning, their intake goes down. And what mirrors that is this is the pH at the proximal stomach. This is the pH at basically the lowest point of the squamous mucosa, which is the place that gets the most common place we see ulcers, which is the lesser curvature. And we see that there's a fairly quick relationship. So as that, and 4 is the magic number. When we talk about pH, 4 is the magic number. So as their feed starts dropping down, even within this 4-hour window where their feed's gone from here, which is good, they've got a pH sitting around the 5 to 6 mark. Even within that 4-hour window, their pH in their stomach has dropped to an average of 4. And when we go out to the 8-hour window, it's dropped to nearly an average of 3. So it's quite a short interval that you start seeing changes in exposure of the squamous mucosa, or at least parts of the squamous mucosa, to increased acid load. The other thing, if you look at this graph, these little lines here give us an idea of the variability, because that's an average effect versus the spread over the population. It's highly variable. So there'll be some horses that makes no difference to, and there'll be other horses that even that subtle change is going to have a really big impact on.
So why is 4 the magic number? It's
the point at which the volatile fatty acids and that all start to denature and become active and cause insult. It's just sort of a threshold between being considered neutral and acidic as well.
Okay.
I would like to just add, can I add one comment? Back in Finland, a lot of people still feed 2 times a day, so their horses are in the stalls or in the paddocks with fairly long times without any hay. And I would just want to address the importance of keeping up in the schedule. If it is the situation where we can't offer the hay as many times as we would want, it is so important to keep up with the schedule.
So to feed them at the same time.
Yeah.
So they're not going longer than, it's a good point, Aira. And I think for you, Tamara, if you're still there with those horses, what you could do from a nutrition perspective is providing a really low quality forage. Like if you can find a nice clean straw, you could leave them straw available so that if they eat all of their much nicer tasting hay, then they've at least got something they can still go and chew on and eat. And in fact, this reminds me too, someone made a really good comment on our forum yesterday, saying that she had a horse that had always been restrict fed because it got overweight, was diagnosed with gastric ulcers, and I'm pretty sure on a gastroscope. And when they treated that horse for the gastric ulcers, it stopped eating everything in sight. Like it wasn't so driven to eat. And what her thinking was that because its gut was sore, it was trying to eat and chew all the time to kind of resolve the pain, to get the saliva down there, I guess. So it's a little bit of a catch-22, isn't it? Like you restrict feed them, but then if that causes ulcers, then potentially it's going to drive them to want to continue eating even more and eat their feed even faster. But it's a great situation, I think, for straw, for any of us that have got horses that can't truly have ad lib access to hay because they get too overweight. Just trying to use really, really low quality forage is a good idea. Lets you give them massive amounts of bulk with very little calorie.
Yeah, and we use, for my own horses, we use just dry cut pasture hay, primarily ryegrass from a paddock of ours, and everyone frowns at us that we've got this rough looking dry hay and they're feeding all this, we go to competition, everyone's feeding all this beautiful lucerne and stuff like that. My horses are sitting there munching all day on something. Their horses are finished in 5 minutes. I'm willing to bet my horse has got a happier stomach. The hay doesn't look as good. It's not. It's like having the old rug that's not as shiny as the new rug. But if the old rug's waterproof and the new one's not, I know which one I'd rather be wearing in the rain.
Yeah. I know hay producers laugh at me when I say, "Oh, that's beautiful hay," and they think it's terrible because it's stemmy and stalky and horrible. But anyway, I know we could keep chatting for hours and hours, but we really must leave it there. We've still got some very committed people hanging with us. If you guys haven't answered the poll questions, quickly jump over there and do that. Massive thanks for joining us. Big thanks to you, Ben. You have redefined the way I will be speaking about ulcers in the future. I've learned a ton from you. I'm sure Aya and Sam have also learned a ton from you. And I know that everyone who has joined us will have learned a ton from you as well. So really grateful for your time and for you to be willing to hang out with us here at FeedXL and do this sort of education work with us. And I dare say we will hopefully do another one with you at some stage in the future.
Pleasure. Thank you for everyone's attendance and participation and lots of great questions. So it's always nice to talk about what are our pet subjects. No, it's been great. Thank you, and thank you to you, Sam and Aya, for all your help with the chat and keeping everyone well looked after there as well. So thank you, and I will see you all around at some point in the future.
Thank you, everyone.